Hello everybody, my name's Lizzie Dodd. I am delighted to welcome you to the first of the ASNEN webinars. We've got a great programme booked throughout the year, which you will hear about. We've got a fantastic speaker today. A little bit of housekeeping that Stacey will take you through, just so you know what to do with your questions and answers. Over to you, Stacey.
Hey all, welcome. So as you can see that you all have been put on mute to begin with, and we all ask you to all stay on mute throughout the presentation just to reduce the background noise. There is a Q&A panel that you can ask your questions in at any time, and there is also a chat function where you can comment amongst yourselves there. This event will be recorded by us today, and you will be able to view it in the future. And if you have any feedback or any further questions that you were unable to ask today, just get in contact with us. Over to you, Lizzie.
Thank you. So hopefully you're all aware of ASNEN as you've signed into this, the Acute Stroke Nurses Education Network. It's a fantastic place that really wants to promote stroke nursing in Australia. And it's a very dynamic force. Please sign up if you haven't and see what it's all about. There are lots of education opportunities. And I would also like to acknowledge the people that support ASNEN. Of course, it's a not-for-profit organisation, but the Stroke Foundation, the Stroke Society of Australasia, Abbott, and especially to Medtronic. And thanks to Stacey, who's first time up with us today, doing the hard bits behind the scene of making sure it all happens. Now, we've got a treat for you. Skye Acute. She is a legend. She's in Melbourne. She runs the mobile stroke unit, which is a really cool, active vehicle that goes from A to B, saving brains. She holds a master's degree in nursing, extensive background in critical care nursing, and you can't find anybody more dedicated and passionate about stroke. So we're going to talk today about Tenecteplase versus Alteplase. Thank you, Skye. Over to you.
Well, I don't think that I can live remotely up to the hype that Lizzie's just provided me with, but thank you. That makes me sound like a far better person than I actually am in real life. So this topic is one that's probably close to most of our hearts in terms of, you know, we've been using Alteplase for years. We've now got Tenecteplase. What are we going to do? Which one are we going to use? Why would we use one versus the other? And what are some of the practical considerations around this? As both Lizzie and Stacey said, if you've got questions as we go, please pop them up. I may not necessarily see them, but the others will keep an eye on it, and we will have time at the end for questions. So there's lots and lots and lots of literature out there on the use of TPA in ischemic stroke, and we're not going to go through all of that because hopefully that's something that you're all very familiar with, but there's lots and lots of evidence to say that, you know, why we're using TPA and what the studies were that got us to that point that we're now using it internationally. But there's now a new kid on the block. So we've now got Tenecteplase. And Tenecteplase was developed and is indicated for use in STEMIs rather than stroke. But, you know, like all of the sort of previous stroke trials, you know, we start with one drug, and then when something else comes along, you do trials to see which is better. So that's where we're up to at the moment, is, you know, really looking at should we continue using Alteplase or do we switch to Tenecteplase? Are there different situations that means we want one versus the other? So this is a slide that was developed for use of all the various thrombolytics in STEMI. So this isn't stroke specific, but it gives you an idea of some of the properties of the drug. So STEMI use and stroke use both started with streptokinase, but it was very quickly discovered to be quite inferior to TPA. It doesn't have fibrin specificity, and it just didn't work as well, and there was a lot more bleeds associated with it. STEMI use moved on to Alteplase, which we don't use, but we went to Alteplase. So it's a recombinant form of tissue plasminogen activator. and it's got a decent half-life, and they found that improved outcomes for patients with a myocardial infarction versus streptokinase. But then not long after, they moved on to Tenecteplase and found that it has a longer half-life, and it's very, very fibrin specific, which means it's going to really target those fibrin strands that are holding our clots together in our ischemic stroke patients. And for STEMIs, it was found to have improved efficacy and safety profiles compared to TPA. So these are some of the studies that we have then looked at in stroke regarding TPA versus Tenecteplase. So we won't be, while we're going to look at these trials, it's not going to be too heavy on trials. There will be a lot of practical points. So bear with me through the boring part of this bit. So there was, and again, this is not all the trials that are out there. This is a sort of snapshot summary. So back in 2012, Mark Parsons, who's done an enormous amount of work in this space in the Australian stroke scene, had a phase 2 trial with 75 patients, and they enrolled patients who were within 6 hours from stroke onset, who also had a CT perfusion, who met CT perfusion criteria. And what that criteria was that they needed to have a penumbra that was at least 20% bigger than the infarct core, meaning that there was something salvageable. So regardless of what the core was, you had to have a decent sized penumbra, meaning that you had brain to salvage. They also had to have a vessel occlusion, and this could be either in the M1, M2, the PCA, or the terminal ICA. So they did a 3-pronged approach, and they gave TPA, then they gave 2 different doses of Tenecteplase, so 0.1 milligrams per kilo and a 0.25 milligrams per kilo. And they found that overall, patients who received either of the doses of Tenecteplase had better rates of reperfusion at 24 hours, and they had better clinical improvement, and both of these were statistically significant. But when they looked at the subgroup between the 2 different T and K doses, they found that the 0.25 milligrams per kilo was superior to the 0.1 milligram per kilo of Tenecteplase and also the TPA. But importantly, they also found that Tenecteplase had no safety concerns in terms of massive bleeding, symptomatic intracranial hemorrhage, or any other adverse reactions. And you can see from the graphs on the side here the differences between those different groups, and the fact that we saw the better outcomes with the 0.25 milligrams of Tenecteplase than the 0.1 and then the TPA. So then in 2015, there was the ATTEST trial. This was a single center phase 2 probe design. If you're not familiar with the term probe, it's prospective randomized open label blinded endpoint, meaning that patients were randomized, but because of the difference in the drugs, it wasn't, the person who gave the drug was not blinded. They knew which drug they were giving, but the people doing all the outcome follow-ups and assessments were blinded to which drug that the patient had, so that there was no potential bias. So this trial looked at TPA versus Tenecteplase at 0.25. They had 71 patients, and they found no differences in both radiological and functional outcomes for the patients at the end of the trial. And this included the amount of penumbra that was actually salvaged, their NIHSS improvement at 24 hours, as well as their MRS of 0 to 1 at 90 days. But again, importantly, there was no safety concerns. So there was a variable rate of symptomatic intracranial hemorrhages. They used a couple of different definitions, but this didn't reach clinical significance, and also no safety concerns in terms of total bleeding in the brain rates. They did a subgroup analysis of patients with large vessel occlusions, given the previous trial had particularly enrolled patients with vessel occlusion. And they did find for patients with an occlusion that they had increased recanalization rates and improved outcomes at 3 months, which we can see from the grotter bars on the bottom of the screen there. So 2017, we had the results of NOR test, and hopefully most of you will be familiar with this, seeing it was only a couple of years ago. Well, actually 2017 is 4 years ago now, isn't it? Anyway, it's still pretty recent. So this was a phase 3 trial done in Norway in multiple centres, and they had 1,100 patients. So much, much bigger study than the previous studies had been in the phase 2 trials. And they enrolled patients who had symptoms within 4.5 hours, so standard thrombolysis inclusion time points, but also patients who were within 4.5 hours from the time they woke with symptoms. So because their actual onset time was unknown for that group of patients, they used MRI, DWI and flare mismatch to try and show that there was essentially cherry picking those patients that they thought they were going to do, who were going to do well, because obviously you don't want to give any of the lytics to patients who have got, a massive established core. So by picking a difference between the DWI and the flare, if you've got a lesion on DWI and it hasn't yet reached flare, it usually means that it's very acute. So even though they were within an unknown time frame of onset, but within 4.5 hours of waking, it meant that they probably were within about a 4.5 hour window. So safety-wise, they felt very confident that these patients would potentially do well. So they again looked at TPA, but instead of using 0.25 of Tenecteplase, they used 0.4, so a much higher dose. Keeping in mind that in STEMIs, they use a 0.5. So all of the stroke studies so far have been under the STEMI dose. So this is the one closest resembling that. And they found that the TNK was not superior to TPA, and portion of patients who were MRS 0 to 1 at 90 days was non-significant. Again, you can see in the Grotter bars that there was a trend to slightly more patients, but it didn't reach clinical significance. Again, no safety concerns, which is great. But one of the things we've got to keep in mind with this trial is the fact that the median NIH for these patients was only 4. So we're looking at a fairly mild patient group. They also had a 17% stroke mimic rate enrolled who were treated. So that's obviously going to skew your outcome data because you would expect these patients to return to normal. So not significant, but also a couple of faults in the actual trial design itself. So following this, there's been a meta-analysis done in 2019, and it looked at 5 trials, including our Australian Tenecteplase trials, a test, NOR-test, and Extend-IA TNK, which we'll talk about a bit later. So they looked at TPA versus the 3 different doses of Tenecteplase that has been trialled, so the 0.1, the 0.25, the 0.4. And their conclusion was that the accumulated trial data indicates that TNK is non-inferior. So they haven't been able to prove for these patients that TNK is better than TPA, but it's at least as good and no safety concerns. So based on that, the paper concluded that they thought that it was reasonable that guidelines then consider recommending TNK as an alternative agent. So they're not saying you should use it instead of, because it's not yet proven to be better, but because it's at least as good, according to them, then it should be, you can basically pick from an either or situation. And my apologies that the graphs and the forest plot is a little bit hard to read, but you can see from that there is again that shift, but they just didn't reach significance for proving superiority. So they've recommended that TNK be included into guidelines as an alternative. So what do the guidelines in fact say? So these are the Canadian stroke guidelines, and they have said that for patients with a disabling ischemic stroke who present within 4.5 hours, my apologies, should be treated with Alteplase. So they haven't got Tenecteplase in their guidelines, they're still saying Alteplase. These are the UK NICE guidelines, and they say that for an acute ischemic stroke presenting within 4.5 hours to use Alteplase as well. The Americans have 75 different guidelines, and you've got to remember for America, TPA is still only officially licensed to be given within 3 hours. So anything beyond 3 hours for them is technically off-label use, but obviously most centres do up to the 4.5 hours. So they've said that acute ischemic stroke patients who present within 3 hours should be treated with Alteplase. For patients beyond 3 hours, so between the 3 and 4.5 hours, selected patients may also be given Alteplase. And patients with mild stroke who are also within that 3 to 4.5 hours may also be given Alteplase. But then they do say Tenecteplase can be considered, but at the 0.4 milligram per kilo dose. And it's not been proven to be superior, but could be considered as an alternative. So our Australian guidelines put out by the Stroke Foundation have said that potentially disabling strokes within 4.5 hours who meet criteria should receive thrombolysis. So we're the only ones saying, not actually saying a drug, we're saying they should be treated with a lytic. There is then a weak recommendation to say for patients without large vessel occlusion, because we're going to talk about alveos in a moment, then Tenecteplase can be used, but as an alternative to Alteplase. So the guidelines basically saying use either, but in patients without LVO, you could consider using Tenecteplase if you wanted to as an alternative to Alteplase. And this is one of the biggest benefits, I think, of our Stroke Foundation guidelines here in Australia compared to the rest of the world. Ours are living guidelines, as I'm sure by now you're all aware, meaning that rather than producing, a booklet that's 1,000 pages thick of all the guidelines and all the evidence, which means that whenever you want to publish a change to it, you need to basically review all of the literature at once. And so it takes years to do. Our Stroke Foundation guidelines can respond very, very quickly to changing evidence and within a few months reflect what current evidence-based practice is out there. Oh, lost my arrow. There we go. So that's the guidelines. But I think, we have to point out the fact that guidelines are one thing, but actual licensing agreements are completely different. So at the moment, as it stands in Australia, TGA, Therapeutics Goods Association, has licensed Alteplase for acute ischemic stroke for patients who present within 4.5 hours of onset. And so that's fine, but Tenecteplase is not TGA approved. It is still the only indication for Tenecteplase is for myocardial infarction. So it's great that the guidelines say that you can consider using Tenecteplase, but you must be aware at your institution that it constitutes off-label use. It is not authorised to be used for this, and therefore it has to be a discussion amongst all the relevant stakeholders in the hospital about whether or not you want to go down this path. So moving on, that was all sort of within normal 4.5 hours. So what happens after our 4.5 hours for an ischemic stroke? So we had the Wake Up trial published in 2018. This was a multi-centre randomised control trial of Alteplase versus placebo, because now we're outside our normal guidelines. And they included patients who had an unknown onset. They had to be more than 4.5 hours though. So anybody who was within 4.5 hours, you wouldn't randomise them to a trial that they could potentially get placebo, because we've got the evidence to say they should be lysed. So this was patients outside this time frame. They had 503 patients, and roughly the last known well-timed treatment time was about 10 hours. However, like the other trial, they used MRI, DWI and FLAIR sequences to look at the age of the stroke, meaning that while officially last known well to onset was about treatment was about 10 hours, the reality was most of them are probably within that 4.5 hour time period. But it's using our advanced imaging to actually say, yes, this patient can potentially benefit from treatment, rather than, them wheeling in the door with the paramedics and you say, there's nothing we can offer them. So they found, as you can see, again, by the MRS grotter bars there, improved functional outcomes, but there was a small increase in symptomatic intracranial hemorrhage. But despite this, they still had overall better numbers of patients achieving an MRS of 0 to 1 at 90 days, no significant increase in death and dependency rates, despite that small rise in interparenchymal hemorrhages type 2 for a symptomatic hemorrhage. So the Extend IV trial was the Australian trial led by Bruce Campbell and the Extend investigators that I know a number of you will have been involved in. So this was published in 2019. Again, it was a multi-center randomized control trial of Alteplase versus placebo. And the study design for this was a little bit different. So they took patients from 4.5 hours to 9 hours, so no more than 9 hours, or patients with a wake-up stroke. And for patients with a wake-up stroke, they found the midpoint between the time that the patient went to bed, the time that they woke up with symptoms, divide that into wherever that midpoint is, and then add 9 hours onto that. So that meant, from a practical perspective, that the last known well time to treatment time was closer probably to around 16 hours. So really pushing that time frame. So they preferentially used CT perfusion as their marker of brain function at the time that patients came to hospital, or MRI if they could. And it was terminated after 225 patients for equipoise. So they found a higher percentage of patients with no deficits or only very minor deficits, despite, again, a very small increase in the number of patients who did suffer a symptomatic intracranial hemorrhage. So you can see here that the number of patients who achieved an MRS of 0 to 1 at 90 days was significant. They had higher recanalization rates. They had non-significant changes in death rates and that very slight rise in symptomatic intracranial hemorrhage. So a meta-analysis was then done, and this was published in 2019, looked at 414 patients who received either Alteplase or placebo, using either CT perfusion mismatch or MRI mismatch, and found, again, patients who more patients had an MRS of 0 to 1, despite a small increase in symptomatic intracranial hemorrhage and no significant rise in death. So overall, patients who had salvageable brain tissue did better, meaning that using this advanced imaging, picking those patients who have got a small core and a decent sized penumbra, meaning that there is brain to be saved, did better. And for those who didn't have automated software showing the actual mismatch, there was no benefit to these patients. So these software programs that can measure this and give you an idea of what's actually at risk and what is likely to have already died can be very, very useful in finding these patients who are likely to benefit. And again, higher rates of symptomatic intracranial hemorrhage, but overall, there was still the benefit to patients who received Alteplase despite that small rise. So based on that, what do the guidelines say? So these are the Canadian guidelines again. So they are still using their MRI selection rather than CT perfusion. And they said that Alteplase should be considered after 4.5 hours. And interestingly, they said that the use of CT perfusion imaging remains unproven. And that goes back again to those living guidelines showing that even though there is now evidence that we can thrombolyze patients outside 4.5 hours based on their CT perfusion, not all guidelines are going to reflect that because they just can't keep up with the changing evidence. So the American guidelines, patients who are awake with stroke symptoms or have an unclear onset, but it's greater than 4.5 hours, again with an MRI, DWI versus FLAIR imaging, couldn't benefit from the use of Alteplase. And our Stroke Foundation guidelines, patients who meet perfusion mismatch criteria, who are up to 9 hours from onset. So rather than just saying more than 4.5 hours, we've said up to 9 hours, or from that midpoint of sleep, should be considered for Alteplase. And then there's a weak recommendation for those with who meet MRI perfusion. So we've said CT is what we should be using based on this study. However, if you can access an MRI, then there is still potential benefit for using Alteplase for these patients as well. So basically, no matter which way their imaging goes, if they meet the criteria, they can be thrombolyzed. So none of these trials have yet used Tenecteplase, which is why Alteplase is still recommended for this population. So they're all our non-LVO. So what happens for patients with large vessel occlusions? So one of the biggest bodies of evidence for this, again, has come from Bruce Campbell and all the ASNEN investigators. And again, this will be trials that a lot of you will have been involved in. And they really have changed the face of Australian stroke care, which is incredible. So this was published in 2018. So it was a multi-center trial, again, that probe design. So prospective randomized open label blinded endpoint, looking specifically at Tenecteplase versus Alteplase for patients who had a large vessel occlusion in either the ICA, the MCAs, or the basilar artery, and they had to be within 4.5 hours. And they were testing non-inferiority and superiority of Tenecteplase. So they wanted to see if it was as good as, but ideally, could they actually show that it was better than TPA? So 202 patients, and as you can see again from those grotto bars down the bottom, Tenecteplase was associated with higher rates of reperfusion and better functional outcomes. So they saw higher rates of reperfusion, which was either complete resolution of the clot or at least 50% rates of reperfusion. So 22% of Tenecteplase patients versus 10% of TPA. And what's important here is they reached statistical significance for not only non-inferiority, but also superiority. So then they also could show that there was a overall median shift in MRS for patients who went from 3 to 2, but they didn't quite reach clinical significance for overall patients within the 0 to 2 MRS at 3 months. And no significant safety concerns in either proportion of patients who died or had asymptomatic intracranial hemorrhage. So this study found that Tenecteplase was in fact superior to Alteplase for patients with large vessel occlusions. So given the fact that that was TPA versus T and K, they then did Extend-IA T and K Part 2, which then said, all right, well, we know that T and K is better, but what dose? So the other trial used 0.25 milligrams per kilo. So this trial used 0.25 versus 0.4. So there was no Alteplase arm for this. It was a head-to-head Tenecteplase at 2 different dose strengths. So same sort of criteria, patients had to have a large vessel occlusion, ICA, MCA, basilar. They had to be within 4.5 hours. And in this study, they had 300 patients. And what they found was that there was no significant improvement in either reperfusion or functional outcome rates for patients who were in the 0.4 milligram per kilo arm. So reperfusion didn't meet clinical significance, as did in patients in 0 to 2 or 0 to 1, or those returning to baseline. But again, similar to NORTEST, they found no concerns from increased rates of death or symptomatic intracranial hemorrhage. So while the 0.4 is not beneficial, it's not doing anything more for our patients than a 0.25, it's not seemingly harming them at least, which is good news. So there's less recommendations in the literature about this because, again, these are fairly new trials and new publications. So there's only, obviously I didn't search every country's guidelines, but your big guidelines, Stroke Foundation have said for patients with large vessel occlusion, then they can receive TPA or TNK up to 4.5 hours from the time the patient was last known well. And the American guidelines have said similar. So patients who are undergoing thrombectomy, they can choose a dose of Tenecteplase 0.25 or Alteplase. So the UK and the Canadian guidelines don't have anything on that at the moment. So that's kind of the data of it. So what are you going to do? So there's all this data to say, you know, basically, other than LVOs where we should be using Tenecteplase, what are we going to do for our other group of patients? So you have to obviously consider the licensing regulations. So as I said, by rights, Tenecteplase, even though it's in the guidelines, is still not licensed for use in stroke. So you have to consider that. You have to consider what your local guidelines recommend. So are you going against your licensing authorities and your guidelines, or can your guidelines be updated? but also other practicalities. You know, if we're nurses, we're looking at we want to get this drug drawn up and given to our patients in the quickest, easiest way. So, you know, how easy is it to draw up? How easy is it to give? And this can change depending on what setting you're in, and also the availability in stock. So because Tenecteplase is only licensed for use in STEMIs, if we start using it all for stroke patients, are we affecting places that still use it for STEMI if they're not going for PCI to the lab? So how does it come and how does this differ? So Tenecteplase comes in a box, and you can either get 40 milligrams with an 8 ml syringe, or 50 milligrams in a 10 ml syringe. But at the end of the day, both of these have exactly the same concentration of 5 milligrams of drug per ml. It's just a bigger or smaller syringe, basically. So inside this box, if you haven't seen Tenecteplase, you get your pre-filled syringe, you get an ampule of drug, and you get a transfer device. So you inject your water for injection, which is in your syringe, draw up the Tenecteplase, reconstitute Tenecteplase, and draw it back up into the same syringe. TPA, we're probably more familiar with, and it comes in a couple of different sizes, 10 milligrams and 50s. And most hospitals will have a regime of, depending on the patient weight, you draw up a combination of these. So even though it would obviously be far easier to draw up 1 to 2 50 milligram ampules for all patients, that's the most expensive option. So most places will say, you know, if you can use 150 and then a combination of 10s, so that we're minimizing the cost. The 50 milligram ampules come with a transfer device to move your water into your powder. The 10s don't, so you need to manually draw it up and inject it in. The big thing to note, though, with Tenecteplase is, if you have a look at this photo, and apologies that it's a little bit blurry, on the side of the syringe, so this is at the moment just got the water for injection, you can see the markings of the mils, but you can actually see that there is a weight dose. So at 6 mils, it says less than 60. At 7 mils, it says greater than 60, but less than 70. And at 8 mils, it's greater than 70 and less than 80. And we're talking in terms of kilograms here. This is dosing for patients who have a STEMI. And as I said, they receive a much higher dose. So they're roughly about a 0.5 milligram per kilo. And most of our guidelines are using 0.25. So you need to completely disregard those kilo weight marks there and simply use a standard weight dose chart, which I'll show you on the next slide, like we do for TPA, and draw up purely the required amount of mils, ignoring the kilo mark because it's the higher dose. Hopefully that makes sense. So this is just to show you what I mean. So we're all used to seeing the TPA, you know, you go down, you find the patient's weight and you know how much bolus to give them, what infusion. So we need to do exactly the same for Tenecteplase, and it'll tell us how many milligrams, but also how many mils to draw up. So ignoring those other markings. This hopefully is very familiar to most of you, but if you're not familiar with drawing up TPA, it's just a matter of using the 50s of popping the lids off, using the transfer device to spike your water and then spike your powder on top, invert it so that the water then drips in, and then draw out however many mils you require for your patient's dose. If you haven't seen Tenecteplase, this is what it looks like. So it comes in a box. And inside the box is some plastic packaging. And as I said, you'll have a pre-filled syringe with water for injection. You'll have your ampule of Tenecteplase, and you'll have your transfer device. So to draw this up, it's really simple. You literally take the lid off your syringe, your vial of Tenecteplase, and your peel back the lid of your transfer device. Luer lock screw the syringe onto the Luer lock on the transfer device, spike the ampule, inject the water, reconstitute it, again, stirred, not shaken, like TPA, and then withdraw however much it is that you need per your dosing chart and inject. So very, very simple to give. So administration-wise, as I said, Tenecteplase, you drop your required dose. You push it over a couple of seconds and you flush the line and you're done. So generally speaking, from the time of the neurologist giving the okay to thrombolyze to giving Tenecteplase should be less than probably a couple of minutes. Open the box, peel back the plastic, take the caps off, screw the syringe in, inject, reconstitute, withdraw, push, flush, and you're done. Whereas TPA, obviously, you've got to draw up and give a bolus dose. And this can either be done as a manual push. So some hospitals will use, say, a 10 milligram ampule to give their bolus separately and then drop the infusion, or they'll drop all of the entire dose and use their syringe driver or their IMED pump to purge the bolus dose. And that's just going to depend on local policy as to what your hospital prefers. And then you need to make sure you've got your infusion dose that runs over an hour. So let's talk for a moment about the TPA infusion. So this is purely for TPA because our Tenecteplase is already given. So there's two ways of running your infusion, your hour-long infusion for your TPA. You can either use a syringe driver or you can use an IV pump. So if you're using a syringe driver, syringe drivers take usually up to 50 ml syringes, but patients who are more than 56 kilos in weight need more than 50 milligrams of TPA. So you're going to need a second syringe if you're going to use a syringe driver. So there's then that safety aspect of, while the first syringe is going through, what do you do with the second syringe? Do you draw them both up at the same time and you leave the second syringe labeled on the side of the bed, on the chart table, etc., in the patient's ED room or the stroke unit or wherever it is that you're thrombolizing, hoping to God that nobody throws it out or it gets contaminated or something? Or do you not draw it up until the first syringe is about through, and you have to hope that you haven't gone to tea and somebody else is minding the patient and they actually realize that you need a second dose, that remaining dose, and they actually know to draw it up and administer it. If you're using an IV pump, it takes longer to prime because you've actually got to prime, a full IV giving set versus your minimum volume tubing, which only takes a second. And we know how frothy TPA can get. So it's, very, very common to get air bubbles in your line, and then you have alarms. And if you work in a really busy emergency department, as much as you're obviously supposed to be one-on-one with your patient at this stage, the reality is that the ED nurses may get called away to help next door or do something, or they've turned their back and the alarm's going because there's air in the line because of all the froth. How long does that then alarm before somebody fixes it? Or, again, you've got all this dead space in the line, which means you have to then put up a bag of saline at the end and continue running the rate for an extra however long, usually using about 20 mils. So, is there the risk that the pump has finished and somebody else comes in and just disconnects the infusion line, not realizing that there's 20 mils of fluid roughly in these infusion lines that you've then thrown in the bin, so you've grossly underdosed your patient. So there's a lot of considerations, and there's no right or wrong. It's whatever suits your stroke team, your emergency team, your intensive care team, wherever it is that you're thrombolizing. So the other consideration in terms of which drug you're going to use is also the setting that you're in. So if you work at a primary stroke centre that does not do thrombectomy and you need to do inter-hospital transfers for your ECR patients to a comprehensive centre, you're going to obviously be using paramedics to transport patients. So if you're using TPA, you're going to be sending this patient with the paramedics to the other hospital in charge of your infusion. Hopefully your door in, door out or dido times are so short, the infusion is still going. If you have very, very long dido times, it may be that your TPA has finished, an hour has gone from the time that you started, but realistically, the patient should be turned around and out your door in under 60 minutes, which means that, half of that time has been taken up getting the patient to CT and thrombolizing them. So chances are your TPA is still running. So the paramedics are fantastic, and this is not meant to be a slight to them at all because they do an incredible job. But when you think about, if you've ever walked into another ward because you've been asked to go and help and they have a different infusion pump than you. New equipment can be really unsettling. So, these poor paramedics that respond to multiple hospitals doing transfers, they're being asked to learn within, 2 minutes, all the ins and outs of a new syringe driver or a new infusion pump. And, when you think about all the different pumps that are on the market, and, the reality is that not every hospital uses the same brand. So, you can have different pumps across one unit. So, the poor paramedics are potentially being given any one of these things from different hospitals, and they're expected to be able to manage this en route to hospital with a stroke patient with a drug that they're not familiar with because they don't use it. So, we need these paramedics to be able to troubleshoot. So if there is a little bit of air in the line and they need to troubleshoot that, will they know how to do it? Or will they simply turn it off because they cannot actually make the infusion run? If using a syringe driver and they need to start a second syringe, do they know how to actually start a second syringe on your particular pump? Can they deal with the alarms? Can they deal with air bubbles? All of those sorts of things. So an alternative to this is to change over and actually use their syringe drivers or pumps, depending on what they use. But then you've got potential issues with that as well. If it's a pump and you have to change the entire line, you've got 18 to 20 mils of TPA in that line. So there's the risk of losing that, that drug. And if you then try and compensate for it, there's the risk that you won't compensate correctly because it's a guesstimate. Well, we know it's roughly sort of 18 to 20 for most IV infusion sets. Each manufacturer has something slightly different. And then there's also the cost that you're basically throwing 20 mils of TPA out and drawing it back up just to cover that dead space in that pump. And then if they've got your syringe driver or your pump, they've got to get back to you. So do you pop your pump in the back of a taxi and hope to God it comes back to you? There's the risk of damage, the risk of loss, and the cost, obviously, of bringing it back. So that's into hospital transfers. The other setting I want to mention very briefly is obviously mobile stroke units, because it's where I work. We're not going to dwell on this too long because obviously Melbourne's got the only one, so most of you this won't be a factor for. But, if these do become more prolific across Australia, more of you may see this. But, the MSU is a much, much bigger ambulance than a standard ambulance. And one of the comments that we get regularly is, gosh, there's so much room in here. And there is when you don't have a patient and you don't have everybody in it. But stick a paramedic, a radiographer, a nurse and a doctor and your patient, and there's literally no room to move. You can't move past each other. So this has dramatic impact on the amount, size, weight of equipment that we can have on board. And so we have to have consideration for things like that when choosing which drugs to use. But it's not just the physical space issues, it's about securing it. So, if we're in a accident in the mobile stroke unit, what's considered a projectile that potentially could cause an injury to the staff sitting in the back. And remembering that the role of the mobile stroke unit is all around really rapid pre-hospital assessment, diagnosis and treatment, and also triage of patients to neurosurgical or thrombectomy centres if they need it. So given the fact that we have this important role, we've got to be really conscious, as I said, of how much equipment, what size it is, how much space does it take up. And we potentially are running multiple infusions. So we've got to be really conscious of, what's going where. We don't have the luxury of having, say, an ultrasound machine on board if you've got patients with difficult veins. And we've all had a lot of patients with difficult veins. We know how hard that can be. So, we often have patients that we can barely get a cannula in. So trying to get 2 cannulas to run multiple infusions is a big ask. So this is a fairly common sort of scenario for us, that we might go to a 58-year-old male. His NIH is 19. He's clearly got a left MCA tachy syndrome. He's within 3 hours of onset. He's not got any exclusion criteria for thrombolysis. So we want to thrombolyze this guy, but he's got rotten veins. So we can only get 1 IV into him, but he's hypertensive. And we don't use labetalol first line for antihypertensives. We use nicardipine. It works much better, and that's a whole other entire presentation on its own, but lots of reasons why we use nicardipine. So if we've got nicardipine running, but we need to thrombolyze this guy and we can't get a second line into him, we can't thrombolyze him if he's still hypertensive, but we need to thrombolyze him. So, what we've managed to do is give enough nicardipine to bring that blood pressure down, pause the infusion, flush the line, give the Tenecteplase, flush it and restart that nicardipine to keep that blood pressure under control. Something that we can't do if we need an IV line for an hour-long infusion of TPA. So that's kind of the main points of TPA versus TNK, but just a couple of points I want to go over about thrombolysis in general. So thrombolysis should only be done in a centre that has proper adequate support and infrastructure, and this can include telemedicine sites. So it doesn't matter if you've got on-site infrastructure or you've got telemedicine support, but you need to make sure that you don't have the back of Burke Hospital who thinks, yep, I read the guidelines, I can give thrombolysis, doing it without any backup and infrastructure in their hospital. We need to make sure that our patients undergo really rapid, streamlined assessment and treatment, which means that we want to make sure that our local ambulance services are providing pre-hospital notification, that you're then mounting a code stroke response, whether that's from the stroke team or an ED team, whatever's appropriate for your facility. Rapid patient registration with as much detail given in that pre-hospital notification as possible. And where possible, taking patients direct to CT, which I cannot stress enough. Most EDs, if you wheel a patient into an ED cubicle, offload them off the ambulance stretcher and then go to CT, you're adding about 15 to 20 minutes to their door to needle time, and that's massive. So direct to CT is hugely time saving and is a really simple step. You need to make sure that whoever's on for code strokes can read your CTs, or you've got radiology who can read CTs and give you an immediate interpretation so that we're not delaying TPA or Tenecteplase at all. So rapid decision treatment. If possible, TPA or TNK should be given on the CT table immediately after that non-contrast CT scan has ruled out any form of intracerebral hemorrhage. The exception to this is obviously going to be if you need a CT angio or a CT perfusion scan, which could be for identification of patients who need extended hours lysis, so those beyond that 4.5 hours, you can't treat them until you've got that CTP, or patients who you're putting in a clinical trial that needs these scans done prior to their randomization, their enrollment. So you should be taking a drug box with you to CT. This is a drug box that I've used in the past. It's got all your giving sets, your drawing up stuff, your flush of saline, everything in there. The only thing that's not in there is the actual drug itself, which is collected at triage and taken with the patient. Alternatively, the best option, and obviously this is a little bit more costly, is to get a Pyxis or an Omnicell or whatever your drug safes are in your hospital set up in CT. Your CT should essentially be a satellite stroke CT, like an ED, set up that everything you might need for that patient should be there. If you want to take bloods, there should be blood tubes there. So everything happens in CT rather than in the ED. So the next point is around assent versus consent. So thrombolysis for Alteplase and thrombectomy are now considered standard of care. There's enough evidence to say that patients benefit from this, meaning that consent is not required. Assent is required, so you can go through and speak to the relatives, the patient, whoever's around, and say, this is what we found, this is what we want to give, this is why we want to give it. And patients obviously have the right to say no. It's the same as if you turn around and say you have AF, we want to put you on an anticoagulant. They have the right to say no. However, you're basically telling them that this is what you want to do based on your medical expertise. So you're not actually getting consent. They're basically just agreeing that, yes, you're going ahead. But given the fact that Tenecteplase is off-label, you have to give consideration to whether or not your institution feels that they need to gain consent for this. So some places do. So given the fact that it's not licensed for this, do you go down, rather than an assent path, a full consent, and explain the fact that it's off-label, but this is why you're still recommending it? So that's something that you need to discuss at a local level. So patient preparation for any thrombolysis is ideally 2 cannulas, but this, as we said, is not so important if you are using Tenecteplase, because you can get away with 1. You want your patients on a monitor, you want them in a visible ED cubicle or stroke unit cubicle or ICU bed. You must have nursing staff at hand. You want your OBS chart, be it electronic or paper, to do all your frequent TPA or Tenecteplase OBS. You want a blood pressure cuff that fits, because we must prevent hypertension in these patients, or we're putting them at increased risk of a symptomatic hemorrhage. You want to have some antihypertensives nearby. It doesn't have to be in the room, but you need to know where they are and be able to get them quickly. And obviously you want your stroke protocols with you. So in conclusion, Tenecteplase is recommended for use in large vessel occlusions within 4.5 hours, but the clinical trials haven't yet shown superiority over Alteplase for non-LVOs, and there is a number of phase 3 trials ongoing. A lot of hospitals are involved in the TASTE trial. There's also TASTE-A. So hopefully soon we'll have some evidence to say what we should do, and then we can start lobbying to actually get Tenecteplase registered, or from the TGA licensed for use in stroke. So even though we haven't got superiority across the board, we do know that T&K is non-inferior with no safety concerns compared to TPA, which is fantastic. But this, as we saw, is not necessarily reflected in all guidelines or local protocols. So the Royal Adelaide Hospital, for example, now have Tenecteplase in their hospital guidelines, but this is not necessarily the case in other hospitals. As we said, Tenecteplase is not yet licensed for use in stroke, so we need to consider that. And if you are making the decision between the 2 drugs, you've got to consider, the stroke type. Obviously, if they're an LVO, you want to go towards Tenecteplase, even though it's not yet licensed. But you need to give consideration to where you're thrombolysing your patients. Are there any external factors, like the fact that you need to transfer them, etc.? Do you need to consent the patient if you are using Tenecteplase? And remembering that thrombolysis is one very small part of overall stroke treatment, and it's really great to focus on the front end and the hyperacute management, but we need to make sure that all the other really important protocols still happen, things like your fever sugar swallowing, getting patients out of the ED up to the stroke unit, assessing them for all their ongoing needs, etc. So we need to make sure that we have very, very robust systems and safety checks in place for the safety of our patients. And that's me done. If you have any questions that you don't want to ask on the chat, there is my email, so you are always very welcome to email me. Thanks.
There you go. What did I promise you? Fantastic, Sky. Thank you very much. I don't think yet. I think all these little nurses are so shy. There's no questions out there yet. Come on. There's no such thing as a silly question.
Absolutely.
There were a couple of comments. Awesome is that good Australian word that comes out about your talk, which is lovely. A few equipoise. That got us running to the what's the meaning of equipoise?
Good point. Sorry.
We all thought we sort of vaguely knew, but I think it's where it's not proven. There's no clinical evidence, but it's up to the clinician's judgment. Would that be a fair description of equipoise?
Yeah. Yeah. So it's kind of neutral. Each thing is equal to the other, essentially.
Yeah. Fabulous. And somebody thought Tenecteplase might be cheaper than Alteplase, which has its. I must admit, we do like Tenecteplase. No fuss, no bother, straight in, whack.
Yep.
Somebody had a safe practice point where they didn't use the TNK syringe. It was, once the water was in, it was thrown away, and they used a normal syringe. There was no question of drawing up a cardiac dose. So that's a good practice point when you're writing your protocols as to what you do. I must say, we always go from what's the weight, what's the dose, how many mils is it, and that's what we draw up. I wouldn't have even known to look at the syringe, I must say. So we just pour those up.
And you're right in terms of cost. Tenecteplase is still very expensive, but overall it is that little bit cheaper than TPA because you're only giving one syringe's worth. So the actual box to box, I think, is not, I don't think there's much different. There's only a couple of $100 in the difference, but it's one box versus potentially 2 boxes.
Yes. Lots of positive comments there, Sky, for you. And one person asked, is Tenecteplase also a TPA medication? So yes, basically it's another thrombolytic. So it's however you abbreviate things, but Alteplase tends to be TPA and Tenecteplase tends to be TNK, but they are both thrombolytic. So it's just the terminology you use.
Yeah, apologies if I didn't make that clear in the presentation.
No, I think it was just on the abbreviations for the TPA bit. From that, oh, hang on, we might have a question here. Fantastic presentation. We tend to use TNK here at the Royal Hobart Hospital. Consultant preference because it is easy. So
and this is the biggest thing, you know, as much as it's not indicated for use yet, the reality is that anybody who's used it, you know, if we had our way, we would just use it because it's just so much easier to give. It's less fuss, less mess. You know, into hospital transfers are a breeze, getting patients up to the stroke unit's a breeze. But, you know, it is at the discretion of the neurologist and they have all those considerations in the back of their mind. But I would move to Tenecteplase tomorrow if I could.
Of course. And you know, we watch this space. So, you know, this is a great forum for the ASNEN community we try and keep up to date with what's happening. And aren't you proud that Australia has the living guidelines? If you don't know what I'm talking about, get onto the Stroke Foundation and just look. You can click on whichever topic you're interested in and it will tell you up to the minute information about what's happening. And, you know, nurses' input is taken into that. It's not all medical staff. It's really important. So you can absolutely get on board. So albeit for me to say thank you to Sky. We're closing up now, and the next webinar is going to be on the 21st of April. So invites will come out in a good time, and that's one that we've done in the past, but it wasn't able to be recorded. So we're going to repeat it, and that's anxiety and depression in stroke, presented by the clinical psychologist Jasmine Turner, another excellent speaker. So that will be coming up. Any questions? And if you want some topics, you think I really want to know about that, send me a little email and we'll put it out to the panel. I put my email on the chat line, but lizzie.dodd@sa.gov.au, and we can see what we can do for you. Okay. Anything else, Stacey? Are you there? Is there anything I've missed?
No, I think we're good. The rest have all been comments, I believe.
Yeah. I can see one question to Lizzie. Are you wearing a stroke armband?
Yeah.
Woohoo! Look at that.
Look at that, stroke nurse. Yeah, that's what they do all day, is just stroke the nurse. So it's grand. Yeah, just when you're down in the crowd, you think, oh yeah, she looks like I don't want to go near her. So that's grand. To do. Okay, thank you all. Thanks for attending, and watch this space. Thank you, Sky. You're a legend.
All right. Thanks all. Have a great afternoon.
Bye-bye.